Sige. Good afternoon. I didn't notice that I did close my camera. Let's just wait for others. No, I'm expecting two sections today, sections A and D. Sige, maybe we can start. Um, I just realized that this is the same class gali for the research class, no? Tama ba? Okay, I'm seeing the same faces, sections A and B. Okay. So let's start with the prayer. Miss, let me see who can lead the prayer. How do I change the layout to here? Yun. Sige, let's have Miss Mumbai to lead the prayer.
Good afternoon, sir. Everybody, let us pray. Um, Lord, as we start our lesson for today, we are asking for your guidance and protection that as we listen to our teacher discussing the topics we need for this afternoon, I hope that we will be able to learn and implement these lessons as we listen today. Lord, we are asking for your guidance, and may you bless us and our teacher and our schoolmates. And all this we ask in Jesus' name we pray. Amen.
Amen.
Okay, thank you, Miss Sanya. So once again, good afternoon, everyone. I think it's my first time to see Section A again. No, for Section D, we've been well in touch because you're still under me for nursing research too. No, but the other section is already with Sir Rosello. So I hope everybody's doing well. Kumusta ang research sa Section A? How are you doing? Di na kamo asta. Miss Nicole, you're with Section A, right?
Yes, sir.
How is your research doing?
Mabalik pa kami sa statistician naman ba, sir?
Okay, sige. Exciting. Lapit na lang ang May. Ano lang, reality check. So you will do your final defense on May. So I hope everybody is excited for the completion of your research. So I'm here for your other subject. Bali, I'm taking over the next 3 weeks only for gerontology nursing. No, so let me share my slide. Are you able to see my screen?
Yes, sir.
Okay. So I will be focusing on your gerontological screening tools. Over the last couple of weeks, you have talked about your CGA, Comprehensive Gerontological Assessment, and you were with your previous professors. You had your introduction already with gerontology nursing, and in order to complete your CGA, as part of your comprehensive gerontological assessment, your GN screening tools are part of that, and that's what we are going to discuss. So, oops, I don't think this is okay. So I won't do a very kind of comprehensive orientation for the subject, but just to give you our schedule and your expected output. So you're expected to learn about your gerontological tools, screening tools. So therefore, our goal is for you to really apply that, not just learn in theory. So for week 1, we're going to do the lecture. This is part 1 already of your lecture. It's about 40 minutes. I have a recorded video which I will play with you, but I'm here, I'll just listen. And then after that, I'll give you the link for the quiz. So this earlier today, I gave you the link for the Google Classroom. So I hope everybody was able to join the classroom so that it's easy for me to post the quiz na lang there. For week 2, we'll do an asynchronous lecture. I will post the recording of the lecture for part 2, and also there's another quiz. Now, after today, you can start already making your videos. So I will group you guys into 8 to 10 members each. So probably in a section, there will be about 3 to 4 groups. Each group will have to make the video. So hindi kinanglan nga tanan gid ka mo ma-perform, but you can do it as a group as long as you will have your names listed on the opening slide no, of the video. So the video will be about your application of the screening tool, and I will be the one to assign your screening tool. Okay, so for week 2, you have the entire week to do the video, and then for week 3, I will be sending you your case analysis. I'm not sure if I've posted that already in your Google Classroom. If I have, you can start making your case analysis. So this is not your case study. I'm not expecting you to make a whole case study. I just need your nursing care plan for the case that I have given you. So there's only very limited information that I gave you as data. So depending on your group, you will also you will also do your analysis based on the group number, which you can find in the case analysis data, which I will give you. But the case analysis will be individual. Okay, again, it's going to be individual um, among the group. So, pwede ka mo kakopihanay, bahala ka mo da. Pero of course, I will check your case analysis individually. So, but the video will be by group. Okay? So, the deadline for your case analysis and video will be on week 3. And then we will try to see if we can still have the presentation of the best video and the best case analysis last with the level 4 last time kay nagpa medyo okay ang ila video presentations, no? So hopefully that would be the same for your class. Okay? So any questions for our schedule for week 1 to 3? Oops. Sorry. Okay. Okay. So do you have any questions regarding our schedule? So for week 2, asynchronous man lang na, and then for week 3, I will arrange with you na lang kung saan ka mo ma-present. But the one who will present is only the best, no, the best video and the best case analysis. So questions, clarifications, anyone?
Ikaw mag-grouping, sir, na.
Yep, ako ang mag-group sa inyo. I will send the group listing later this evening. I'm just waiting for the class attendance. I hope you can give me an Excel file. Kaya do kabudlay mag-type liwat. Anyway, questions? So if you do not have any question, I will start with the lecture for part 1. One moment. Were you able to hear the sound earlier? Or wala? Wala may nag-sound?
Wala man, sir.
Kadali lang.
Wala, sir.
Were you able to hear the sound in the presentation earlier?
Wala, sir.
Wala. Paano ni man? Wait lang yun. Dali lang gid ha, one moment. So this is part one of our chapter on gerontological screening tools. So before anything else, let us remember our basic concepts of. Were you able to hear the sound earlier?
Yes, sir.
Gerontology nursing. Again, geriatrics is a branch of medicine. Gerontology is the general term, no, for the care, the science, for the health, welfare, etc. of older adults. Therefore, when you talk about the practice of nursing care for older adults, we use the term gerontological or gerontology nursing rather than geriatric nursing. And so when we go to our screening tools, our assessment, it is more proper to use the term gerontological screening tools rather than geriatric screening tools, because remember that these are multidisciplinary. These are screening tools which can be used not only by the physician but also by the nurse. So, in the past few chapters with your other instructors, you have learned the basics of gerontologic assessment. And as a whole, we call this one as CGA, or Comprehensive Gerontologic Assessment. CGA is a multifactorial assessment system which involves from the review of systems. So you have reviewed the different body systems like integumentary, musculoskeletal, no? And aside from that, you also look into other components such as functional ability. We look into nutritional assessment. We look into spiritual assessment, sexuality. We look into psychological well-being. So all these components, no, in general, will be called your gerontologic assessment, or your CGA, Comprehensive Gerontologic Assessment. And what we'll be discussing today, which is your screening tools, is just a component of your CGA. No? So gerontologic assessment, again, when you talk of comprehensiveness, it does not only include the medical domains, which is more on the body systems, but also the non-medical domains. Again, for instance, we will talk about their financial capacity. So part of the assessment is also their financial protection. This is non-medical domain, but this is part of the comprehensive gerontologic assessment, because this is how holistic gerontologic assessment is formed. It also emphasizes functional ability and quality of life. We do not judge, the scoring, the scale of the screening tools and assessment that we use for gerontological patients are not there to assess whether they are teams. So your gerontologic assessment, again, is multidisciplinary, and therefore it is wrong to call it geriatric assessment, because this is not only the domain of physicians, but also of nurses and other healthcare disciplines, and not just people in the healthcare in this industry, but also those who are also considered non-medical. So you can have financial analysts working, you can have psychologists who are considered gerontological psychologists. No, they are part of the comprehensive gerontologic assessment. And of course, it is there to improve our care and clinical outcomes. It provides greater diagnostic accuracy, because it gives us more more baseline information of a certain condition before we come up with a diagnosis. It is there to improve functional and mental status by, of course, detecting early detection of functional and mental issues. Reduction of mortality, of course, because we look into early detection, decreased use of nursing homes and acute care hospitals, and greater satisfaction with care. So this is now the model of functional status by Halter et al. So as you can see, functional status for older adults is multifactorial. So we not only look into the medical side, but we look into the cognitive and the affective side. So there's also social support, spirituality, environmental, and economic. That's why I said part of the comprehensive geriatric assessment or gerontologic assessment is really the non-medical domains, which includes financial protection, social support, etc. So we move on to our geriatric screening tools. Now, sir, what is the difference in terms of geriatric screening tools with the previous assessment skills that we've learned? No? So your screening methods serve to uncover problems that are not yet diagnosed, and that places an individual at higher risk, no, because of the high prevalence and morbidity associated with a certain problem. And so therefore, it focuses more on early diagnosis and treatment because of your screening tools. So early detection is assumed to be advantageous, no, especially for older adults who without screening may not be identified until overt signs or symptoms can actually occur. So often, this can indicate advanced disease, no, with worse prognosis later on. So that's why your geriatric screening tools as a venue for early diagnosis and treatment is very important. Now, what are the characteristics of our geriatric screening tools? No? So number one, it's usually very brief and concise. So it only contains essential diagnostic information, and therefore, when we use a screening tool for a particular older adult, it follows that when we detect something positive or we detect something that's abnormal or pathological, therefore, we need to do a more detailed evaluation after. So you do a geriatrics or a gerontologic screening tool, you use a gerontologic screening tool, and then you do a comprehensive assessment, which includes probably physical assessment, laboratory diagnostic tests, a more extensive history, etc. So your screening tools should be routinely used for screening. No, this will include a lot. No, fall assessment, functional assessment, pain, cognitive impairment, social interactions, etc. So your choice of a screening tool, no, a gerontologic screening tool, will depend on a lot of factors. So I think I forgot to place this in my slide, but you can take note of this. Number one, you look into the purpose of the instrument. Is this particular instrument intended for older adults? Because, for example, fall assessment, there are fall assessment that is specific for children, for adults, and there are those that are specific for older adults. Limitations of the setting. Your area, for example, or your setting, you are in a long-term facility, and therefore it might be difficult for you to use a screening tool, which would require equipment and other tools which are not found in your setting. No? Clinical relevance is also one thing that you need to remember. For example, if this particular case, you're screening for a patient with a component related to incontinence, is this really clinically relevant? Because it might not be clinically relevant if the patient actually has indwelling catheter. Simply, you cannot really determine that if the patient has incontinence. No. Ease of use is something that we also need to consider, because if this particular screening tool would not be easy to use, you might want to go for something that you think that's easy. Also, very important is the amount of training that you have received for using a screening tool. We do not use a screening tool if we are not trained to do so. No, I remember before. I attended a training on the MOCA, the Montreal Cognitive Assessment Tool. And one of my first reactions then was, I've learned this back
when I was a student. Why do I need to be trained for 4 hours, no, in a classroom setting just to know this one? Because I was attending, I was supposed to do to participate in a mission, no, medical mission, and that was part of the training prior to the medical mission. And so when I attended the training, I realized that there are a lot of things that you really need to learn, okay, that is not that is beyond the classroom setting, and that's why training is very essential, even if it's just for one particular screening tool. Again, you also need to consider equipment needs and costs. So perhaps you need equipment that is quite expensive, appropriateness for older adults, and other special patient considerations, which may prevent you from getting a more accurate result. No, so for example, if you are assessing for, let's say you're assessing medication safety for a patient, and if the patient is not because it is self-reporting, no, self-reported, but the patient has cognitive problems, medyo na, may dementia na, and so you question the accuracy of your results. So that is one thing that you need to consider as well. So in general, when you decide to use a screening tool, you also need to consider the reliability and validity of the tool, you know, whether it has been used in multiple instances and whether it has yielded a consistent result. So let's talk about your first tool. This is your Heinrich Fall Risk Assessment Model. Heinrich 2 Fall Risk Assessment Model. This was developed by Dr. Anne Heinrich. No? It's been over a lot of years already that the Heinrich 2 Fall Risk Model was invented. So we all know that falls for older adults are very common, and this usually occur in multiple factors. No? It could be because of a medication, it could be because of an acute or chronic illness, or it could simply be idiopathic, na fall lang si patient without a certain reason at all, probably because of his or her age. Fall assessment, therefore, should be as common as the occurrence of fall itself. No? And what is more common among settings is that fall assessment happens during admissions. But it is very important to understand that it should not be only during endorsement, but it should be ongoing assessment. Therefore, you will assess now during assessment, and you will assess regularly to determine salient changes, no, incremental changes in the patient's risk for fall. So advantages. So when you talk of the Heinrich 2 Fall Risk Model, okay, number one, it is very quick to use. So as you can see, no, just you can disregard the get up and go test because this is actually a different test, no. But this particular part over here, the bottom part, there are some studies which actually use the get up and go test as an addition to the Heinrich 2 Fall Risk Model, which is found above. So it is very quick, very short lang. No? These are the only items that's being discussed. So risk-based model based on gender. So as you can see, kung male, there's a risk point of 1 because there are more risk for fall according to research. Mental and emotional status, symptoms of dizziness, and other known categories of medications. The use of the two components here, which talks about anti-epileptics or anticonvulsants and benzodiazepines, make the Heinrich 2 Fall model very unique because it did consider the known categories of medications. So what is an advantage? Another advantage of your Heinrich Fall risk model is that it's not only used as a pre-fall assessment, but it can also be used as a post-fall assessment. So for example, if the patient has had an incident of fall now, you have to measure the risk now, and then you will compare it a few days after. This is a form of assessment to determine incremental changes. So whether there's an improvement or decline in the risk, that you have assessed. So for post-fall assessment, this is known as your secondary prevention of falls through the Heinrich 2 fall risk model. So your Heinrich 2 fall risk model is very applicable across all settings, whether you work in an acute care setting like in the ER, in the hospital, or it's ambulatory care setting like an outpatient department, or perhaps if it's a long-term facility like residential homes for the aged, you can use the Heinrich 2 fall risk model. So it is very sensitive and specific, according to the results of Dr. Anne Heinrich. There's about 74.9% sensitivity of the Heinrich 2 fall risk model, and it's also very much reliable, according to the inter-rater reliability test of this particular tool. So again, very important unique characteristic of the Heinrich 2 is the consideration of the medications for high risk for fall. And what is more common now, trend for the Heinrich 2 fall risk model, is that it's being integrated into the electronic records because it's easy to score. You have an app. Sometimes they have an app in the hospital to score the patients in the Heinrich 2 fall risk model. So it actually provides them with easier access through the electronic form. So this is the Heinrich 2 fall risk model. So again, confusion, disorientation, symptomatic depression. Please take note of the word symptomatic. Okay, altered elimination, dizziness, vertigo, gender, male, anticonvulsants, and your benzodiazepines. These are the components of your Heinrich 2 fall risk model. Next is your CATS Index of Independence in Activities of Daily Living. So the CATS Index, very commonly known as your CATS ADL, has been used for over 35 years, almost 40 years. And as we all know, normal aging, there's usually decline in our functions, in our functional status. And the decline in the functional status leads to further problems. And therefore, assessing functional status will provide us with a more objective data to predict future functional declines. And that is why your activities of daily living, or ADLs, are very important, because it measures, this particular tool measures ADLs, for activities of daily living performance, whether it is performed independently or dependently. That's why there's a yes or no there, or dependence versus independence score, 1 versus 0. And there are 6 basic domains in this index. So we have bathing, dressing, toileting, transferring, continence, and feeding. So a score of 6 will give you full function, meaning the patient is highly independent, while a score of 2 or less, or 0, could mean severe functional independence. And in some universities, they also use the score of 4 as moderate independence. So the disadvantage of your CATS index, well, for one, it cannot assess the advanced form of your activities of daily living. For example, using the telephone, doing my laundry, going to shopping. So it's not mentioned there, okay, because these are only the basic ones. And so that is the exact reason why the ADLs, we now have the instrumental ADLs, instrumental activities of daily living. We'll discuss that in the next slide. So again, it does not assess the advanced ADLs. And it is also limited in its ability to measure small increments of change, no, seen in the rehabilitation of older adults. So, for example, if I assess now the ADL of a certain individual, you cannot expect that within a week time there would be some changes, no? Because if the manner of bathing, dressing, toileting, transferring continence, and feeding would somehow reflect almost the same, no? Unless there are certain conditions that actually affected it over time. But it cannot measure small increments. So usually, dako siyang increments. So for example, if I measure it now, a week after I had a stroke, that means a week after there will be extremely a different score for your CATS index. So small increments cannot be measured in your CATS index. That is why it is advised, no, that when we use the CATS index of independence and activities of daily living, it is usually followed by a full performance of your comprehensive geriatric assessment. So after your CATS, you do a CGA. So that is your CATS index of independence of activities of daily living. So this can actually be used not only for screening, but can be used for research as well, no? If you're doing a research for gerontologic patients. Now, we talked about your activities of daily living, and again, it is not advanced, very basic. And that is why Lawton and Brody created the instrumental activities of daily living. So these are more complex as compared to the CATS index. We look into how the patient is right now, and we identify improvement and decline over time. So this is actually the main reason why we're scoring activities of daily living. So according to this score, we are looking into use of the telephone, getting to places, or doing your grocery or shopping, preparing your meals, housekeeping, laundry, mode of transportation, responsibility for own medications, no, taking medications, and the ability to handle or manage your finances. So those are parts of the instrumental ADLs or IADL. So in this particular scale, if you score 0, that is considered, or 8, that is considered a 0, that's low function. And then for high function, you need to have a score of 8 for women and 5 for men and above. So why is it different for male and men? This is to avoid gender bias. For example, there's a component there for laundry. So not all men would probably know how to do laundry. So that's why bawas ang total maximum score, no, for low function for males. Okay, and there's a formula here. No, you have to multiply plus times 1 plus 0. So just look into that. The next one is, let's go back first to your Lawton Brody. So just like your CATS index, your Lawton Brody IADL screening can also be used across all settings, no? And what is advised and what has been recommended according to studies is that we can use the assessment of ADLs to provide safe discharge. No, before we discharge a certain patient, especially an older adult, we can assess whether they can use the telephone for emergencies, whether they can prepare their own meals if they're alone sa ilang balay. This is very common, especially for European and Western countries, no, na older adults can live alone. No? In the Philippines, it seldom happens because we are usually an extended family. We have lolos and lolas at home. But it is still very important to assess their ADLs, no, as a form of way to ensure safe discharge of our patients. It is also easy to administer, just like your CATS index. It's a bit long, but it's fairly easy to use. What is a disadvantage here is that your Lawton Brody instrumental activities of daily living can actually be used as self-report. So you can just give the form to the patient and the patient will just answer it. So that's okay. However, a disadvantage is that this could lead to surrogate reporting, no? Meaning I could, rather than the true functional task. So therefore, I can over or underestimate my ability because I might be ashamed, no, na I can't do my own laundry, kahuluya. So I will use the score of 1 so that I won't be embarrassed. So self-reporting can actually lead to over or estimation of functional ability. No? And just like the CATS index, it cannot measure as well small increments of changes. So because these are activities of daily living, so usually these are macro changes that it can detect. So the next screening tool is known as your Fulmer Spices. Fulmer Spices, authored by Dr. Terry Fulmer. In normal aging, there's always inevitable changes. In fact, some would use the term irreversible changes, no, in our body, almost in all parts of the body. Remember the wear and tear theory in gerontology nursing. So what is advantageous for the Fulmer Spices tool is that it actually uses components which are prevalent issues on aging. For example, sleep disorders, problems with eating and feeding, incontinence, confusion, evidence of falls, and skin breakdown. All these are actually acronym for your spices. So SPICES. Okay? So it is a very efficient and effective tool in obtaining information that we can use to prevent health alterations, especially among older adults. So a very important characteristic of your Fulmer Spices assessment tool, number one, it is holistic because it actually looks into the most common issues among older adults. Second, consider Fulmer Spices as very specific for older adults. This was created specifically for older adults, and therefore it can be used for both the frail and the healthy older adults. So your SPICES acronym is very easy to remember, and that can perhaps be considered as an advantage, And it's a very simple system. It's just yes and no, yes and no. So even if it's this simple, it can still provide us with a standardized quality of care using certain parameters that we can all understand, because this is very easy to comprehend. A disadvantage is that remember that your this particular tool is only considered as an alert system. So these are only among the frequently occurring issues among older adults. Therefore, there are other issues for older adults which are not mentioned here. For example, joint pains, that could be very common. I don't know, that is just my opinion. That could be very common, but it's not found actually there in the tool. And so therefore, when we use the Fulmer Spices assessment tool, it should trigger additional assessment. Again, it should trigger additional assessment after using the tool. Okay, so it should not be a replacement of our comprehensive geriatric assessment, but rather it should be complementary. The last one for this particular, this is the second one for the first part of our video lecture. This is the Pittsburgh Sleep Quality Index. So the Pittsburgh Quality Index, Sleep Quality Index, or the PSQI, have been revised multiple times. So there are some revisions, but what I'm showing you here is the basic one. So this was created back in 1988, and it assesses sleep disorders among older adults using the 7 areas, 7 components. So component 1 is more on subjective sleep quality. Component 2, as you can see in the right part, is more on more on sleep latency. See, number 3 naman, which will ask you how many hours of actual sleep did you get at night. So this is more on sleep duration. Component number 4 would be your habitual sleep efficiency. Component 5 is sleep disturbances. So it will ask you what are your sleep disturbances. Component 6 is using sleep medications. Are you using sleep well, kag ano pa da? And the last would be daytime dysfunction over the last 1 month. So first thing that we need to remember, when we use the Pittsburgh Sleep Quality Index, you have to emphasize that the patient has to reflect within the past month, 1 month. And therefore, it should not be something that I have experienced 6 months ago, but if there are changes, so I need to indicate my score based on what I've experienced within the last 1 month. So you will be asked of your what time do you usually go to bed? How many minutes does it take for you to sleep? How many hours, actual hours, do you sleep at night? How many hours are you in bed? Because sometimes you could just sleep, bangon, pamahaw, kadto sa sopa, tulog liwat. So you consider the number of hours that you're actually in bed. So sleeping disturbances, so cannot sleep, get sleep within 30 minutes, wake up in the middle of the night or early morning, have to get up to use the bathroom, cannot breathe comfortably sometimes, cough or snore loudly, feel too cold, feel too hot, have had bad dreams or has pain. That's why magabugtaw sila, and other reasons. No, you're also asked how often have you taken medications, have you had any trouble staying awake while driving, eating meals, engaging in any social activity now during the daytime. You'll also be asked of how much of a problem is it for you? How do you rate the overall quality of sleep? So there's a scoring system here, as you can see on the right upper part of this slide. So component 1, which talks about your subjective sleep quality, will be asked of how would you rate? Okay, so 0, very good, fairly good, 1, 2, fairly bad, very bad, 3. Component number 2 is for question number 2, which is more on how long, because this is duration. And there's a scoring there. So if it's less than 15 minutes, makatulog na ka, 0. It's 60 to 30 minutes, score of 1. 31 to 60 minutes, meaning 1 hour, score of 2. Or more than 1 hour kung magligid-ligid that before you sleep, score of 3. Plus, you add this one to your score in 5. 8, which is not get sleep within 30 minutes. So not during the past month, week or once or twice a week, score of 2, 3 or more times a week, score of 3. So that's your component number 2, which is more on sleep latency. Third is question number 4. Now, component number 3, which is sleep duration. So you have what time have you usually gotten in the morning? So do you have a score there? If it's 7, more than 7, 0. If it's 6 to 7, 1. If it's 5 to 6, 2. If it's before 5 a.m., should be 5 hours should be score of 3. Component number 4 is more on habitual sleep efficiency. So you have a score there as well. This is more on there's a formula there for total number of hours divided by total number of hours in bed times 100. Component number 5 is more on sleep disturbances. So you have a score there from 5B to 5J. So kung 0, wala ka gida magiging ano, so that's a score of 0. But if you have 1 to 9, score of 1, 10 to 18, score of 2, 19 to 27, score of 3. Component number 6 is using sleep medications. So that's question number 6. So if you've been using it within the past month, 0, less than 1 week, 1, once or twice a week, 2, 3 or more times a week, 3. So that's your score for component 6. For component 7, you use question number 7 and question number 8. You add them together and you have a scoring there. You add everything from component 1 to 7, okay, and that is your global PSQI, or Pittsburgh Sleep Quality Index. So a total score of 5 or more is indicative of poor sleep quality. If you scored 5 or more, it is suggested that you discuss this with your healthcare provider. So you can actually use this Pittsburgh tool not only for older adults, but you can use this for adults. Therefore, you can use it for yourself. No, are you getting enough sleep lately? The next part, the last part for part 1 of this lecture video is the functional reach test and time up and go. So I want you to watch this video before I end.
For many primary kids, math is, well,
In this video, we will look at the functional reach test. The purpose of this test is to assess a patient's stability by measuring the maximum distance a person can reach while standing at a fixed position. To begin, ask the patient to stand perpendicular and close to the wall with their arms forward. Then, instruct the patient to extend the arm forward as far as possible without losing balance. Using a tape measure or ruler, measure the difference in arm stretch from standing to the reached position. If functional reach is less than or equal to 10 inches, then he or she has increased risk for falling. In this video, we will look at the timed up and go test to assess fall risk in the elderly population. The timed up and go test has been rated both 87% sensitive and specific in identifying elderly who are at risk of falls. To conduct the test, you need a chair, a timer, and an object to mark a line on the ground 3 meters away from the chair. Have the patient sit on a chair with possible walking aids at hand, and then explain the procedure to your patient as follows. When I ask you to start, please get up from your chair and walk at a comfortable and safe pace to the mark 3 meters away from you. Cross the line, turn around, and then return to your chair and sit back down again. Could you repeat that to me? If your patient understood the process, ask the patient to start the test. Once you ask the patient to start the test, you will start the stopwatch and only stop until the patient is seated again. Okay, you may start. The patient is allowed 1 practice round and 1 round is timed. Amongst other risk factors such as history of falls, poor vision, or certain medications, or a time of 12 seconds or more during the timed up and go test, or if your patient is already unsteady, this could indicate a higher fall risk.
All right, so that's part 1, no, of our lecture on the gerontological screening tools. So I will be posting again a 10-item quiz in your Google Classroom. So make sure to join the Google Classroom tonight to get the notification. Okay, and then again I will post the groupings, no, for the screening videos later. So technically guys, GN screening tools wala masyado ano, it's just the application of the tools. Amo lang gid na ang aton nga goal, no, for this particular topic. because the principles, the major principles for assessment, should already be learned in your foundations, no, in your other the other parts of the assessment. Do you have any questions, clarifications regarding your gerontological assessment? Let's stop calling it geriatric nursing. I really don't like that term, geriatric nursing. In our masters and in the post-grad, we always call it gerontology because that's the correct term. Any questions regarding your gerontological assessment? Wala na, tulog na. Everyone, okay lang
Answer.
ka mo? Okay. I hope to see you in person, hopefully. I for section D, I told them na I might be coming over the first week of May. Kaya I might be visiting Sagay. So, well, wala man need nga mag face-to-face for this class, but hopefully I can also see you guys for wala lang, just to say hi. Okay? So I hope you learned something for this today's session, and then we'll have the part 2 next week, posted as asynchronous learning. And then once you have your group listing, talk among your group so that you can plan for your videos. Okay, for the videos, by the way, you don't need to find a patient gid nga layo, ha. You can do patients nga mga tupad balay nyo, or you can ask your lolo lola. Okay, there's also no specific age kay kasi sir pwede 51. Yes, because that's still under young old, di ba? Older adults have 3 classifications. You have young old, middle old, and old olds. So you can also use the 50 years old and above if wala gid may makita. Okay? Tapos sir kinanglan gid nga naka-anonymize. Mas mayo gid nga naka-anonymize, but if you can't do it, then that's okay. As long as you have your names. Amo lang ginang iban ga-send video wala names ang group members. Okay? Questions before we end?
Sir, excuse.
Yes, sir.
Kasi sa recorded lecture mo, sir.
Ano? I will be sending the recorded lecture. Yes, I will be posting them in the Google Classroom also.
Thank you, sir.
Okay. What else, everyone? Okay, sige. Can we have a group photo before we end? Okay lang. Para makita ko man yung mga tsura kag o diba? Si Sir Roniel, wow, kumaka ngirit wagas. Siya lang nag-open ara. Sige ba? Okay. Wow. Ay, ako di ay wala ko nag-open sa akong camera. Sige. Sige, di na iban. Next. I see your pictures on Facebook, so I know your faces in your uniforms, but I don't know your. Oh, my baby. Hi, baby. Okay, let me take a screenshot. Okay. See, hope the week goes well for everyone. I know you have exams pa ang iban waay na. And good luck to your previous exams. Have a good night and thank you.
Thank you, sir.
Bye, sir.
Thank you, sir.